Okay, welcome to the session on the title of TAVR, Key Issues in 2024. I'm H.S. Kim from SNU Hospital. My co-moderator is Dr. Eberhard Grube from Germany. And we have 5 lectures for 8 minutes. Then we are going to have discussion time. The first speaker is Dr. Eberhard Grube. The title of his lecture is Essentials of Lifetime Management of Aortic Disease, Updated and Novel Points in 2024. Dr. Grube, please.
Yeah, thank you very much, and I appreciate your attendance, obviously, in difficult times here in Korea. And obviously, the organizers didn't want me to talk about lifetime management, but much rather take updated and novel points in 2024. So I would do some flash points, start with my financial disclosure, and those will be my roadmap. I would like to give a few introductory remarks, and then some novel points in selected indications, and then a final statement. The TAVR, as you all know, is roaring. The numbers are roaring. They're going up. 85% of all replacements today is, at least here in the United States, TAVR, and we treat more patients, twice as many patients successful based on TAVR. Very important, improved patient selection and disease awareness. We have to concentrate on how to manage patients earlier on. 30% of patients undergoing TAVR derive only minimal symptom benefit or die within 1 year. Therefore, earlier interventions are most likely needed. Very important. Also, lifetime management in aortic disease, when we look at valve-in-valve situations, we'll discuss this topic later. We look at valve performance, optimizing the first implant, and of course, physiologic valve orientation. Last but not least, we have to realize patients are getting more educated, the internet is working, patients need to be part of the decision-making. So let's talk to then updated novel points and selected indications. Asymptomatic moderate aortic stenosis. Michael, I guess, will talk about this later. Why are we targeting this very, very important group? We are targeting because of the circled indications on the right side. You can see there's a discrepancy between 4-year treatment rates with replacement and mortality, particularly in mild and moderate aortic stenosis. There's a huge gap and discrepancy. We need to close those, and that's why we're dealing with moderate aortic stenosis. Watchful waiting is ingrained in clinical practice as of now, and we know moderate aortic stenosis is not a benign disease. Transcatheter studies are coming up, TAVR Unload, Progress, and Expand. And TAVR Unload the enrollment is complete and will be presented at ESC or TCT of this year. Next, aortic regurgitation, an extremely important topic. We do have valves now, specific valves that are addressing aortic regurgitation, the Jenner Trilogy valve and JC Medical's J-valve. Very important. The results here, the Jenner Trilogy valve presented at TCT, excellent elimination of aortic regurgitation, patients are feeling better, great hemodynamic valve performance, and the left ventricle is remodeling. Very good news. However, it's time to redefine what is moderate aortic regurgitation, not wait until it is severe. Growing data suggests that VHD guidelines are outdated and they are recommending treatment too late. We should not wait for symptoms, and we should not wait until the ejection fraction is lower than 55, what's recommended now. If we go back to the ALIGN trial, it took 3 years to complete the study. Why? First, screen failure rate was anatomical reasons, large annuli, etc. But the second reason was grading by echocardiography, non-severe AR by echocardiography. That was the problem, enrolling the patients. Now we know there's a poor agreement between echo and CMR grading the severity. That has to be taken into account. Disease awareness has to be increased and grading has to be redefined. Significant aortic regurgitation is not uncommon, but terribly underdiagnosed. 2D echo is inadequate for quantification of AR severity and of LV remodeling. forget linear dimensions. The guidelines are outdated. Don't stop at moderate aortic regurgitation echo. Use CMR to confirm. While the current goal is to address the immediate need in HR and in our patients, true success will be measured by transforming diagnosis, selection, and treatment of AR patients to an earlier stage. Small annulus, something very important. SMART trial has been discussed and published recently. You all know it's a small annulus patient cohort randomizing self-expanding valves versus balloon-expanding valves in blue and in red. The co-primary endpoints at 1 year with planned 5-year follow-up. The co-primary endpoint, composite of mortality, stroke, heart failure, rehospitalization through 12 months, and co-primary 2, bioprosthetic valve dysfunctions, BVD, through 12 months. Co-primary endpoint 1 has been met. Clinical outcome composite through 12 months powered for non-inferiority, self-expanding versus balloon-expandable, not different. However, BVD to 12 months powered for superiority, as you look to the left side, has also been met. So BVD through 12 months superior to balloon expandable valves. Other hemodynamic outcomes at 12 months, Doppler velocity in favor of self-expanding valves, severe posterior patient mismatch, VARC3, in blue, self-expanding, and then very interesting and surprising, total aortic regurgitation between self-expanding and balloon-expandable valves on the right side, also different. So the SMART trial met both primary and all 5 pre-specified secondary endpoints. Compared with balloon-expandable valves, the supraannular self-expanding demonstrated non-inferior clinical outcomes at 1 year, superior valve performance at 1 year, and improvements in other secondary outcomes at 1 year. Based on the large differences observed in valve performance, the authors expect that the self-expanding valve will demonstrate improved valve durability and outcomes during longer follow-up. Last, durability and valve, the good news, severe SVD and BVF are low. Valve situation, you can see here is a growing interest, very important, and we can see here the market forecast in the United States. The numbers are growing, so we have to deal with valve situations definitely. You have to be, if we're in the decision-making process for valve presentations, we have to look at patient selection, pre-procedural planning, and procedural aspects. Lifetime management, first intervention TAVR. Clearly, the second should be TAVR-in-TAVR. The same on the right side, first intervention TAVR, TAVR-in-TAVR preferred to TAVR Explant. The first cut is the deepest. TAVR will likely be the most frequent second intervention in a lifetime management, and TAVR repeatability might be as important as leaflet durability. What else is important? Neoskirt, leaflet overhang, and index THV expansion. Leaflet modification methods such as basilica and shortcut may be coming up more. iPhone app for THV and THV will be coming soon in 2024. Final thoughts, older, more than 75 years by ESC guidelines, regardless of patient risk, TAVR is the first-line therapy. Younger and low-risk surgery, 2022 guidelines, surgery is the first line. However, many aspects need to be discussed for final decision: frailty, futility, adequate informed consent, life expectancy, redo permutations, TAVR repeatability, such as coronary access, and unfortunately or fortunately, not all TAVR centers are created equal. With that, I would like to thank you for your attention.
Really wonderful lecture. Really. Thank you very much. The second speaker is Dr. Philippe Garot from Institut Cardiovasculaire, Paris, France. The title of his lecture is TAVR-in-TAVR, the next challenging issue in lifetime TAVR management. Dr. Garot, please.
Thank you very much for the very kind invitation. These are my disclosures. As you know, we are treating more and more patients with TAVR, younger patients with longer life expectancy, and as a result, a non-negligible number of THV are expected to fail and require repeat intervention. Optimal TAVI procedure, index TAVI procedure, is key to optimize clinical outcomes and THV durability. Coronary access and treatment options for the future is key for the future, sorry. We know from the Explant TAVI interventional registry that Explant is really an issue with a 25 to 30% mortality at 1 year. On the other hand, redo TAVI is relatively safe and effective with low rates of procedural complication, substantial benefit in terms of symptoms, and a 1 year survival rate that is comparable to that reported in recent TAVR-in-TAVR or TAVR-in-native valves in high surgical risk patients. Coronary access may be impaired after redo TAVI procedure, and factors impacting coronary access are anatomical and non-modifiable or may be related to the device or the procedure, as you can see here, especially commissural tab orientation, sealing skirt height, and valve implant depth. The design of the index TAVI procedure is associated with different risk of sinus sequestration and coronary obstruction. When the first THV is a balloon expander valve, you can see that the risk of coronary sequestration is 28%, which might require leaflet intervention. This increases up to 91% and 75% in BEV in ECV and SEV in ACV. In these cases, leaflet intervention should be considered a prerequisite of a redo TAVI procedure. The optimal THV design and implantation technique for redo TAVR are poorly understood. The leaflets of the failed THV may create a tube graft in which the index THV leaflets will be jailed between the two THV frames, creating a new skirt of tissue from the inflow of the failed TAVI to the top of the leaflet of the valve, which may limit subsequent coronary access and coronary blood flow. Depending on the frame height and position of the second THV, the entire leaflet of the index THV may not be fully entrapped between the two THVs. The resulting new skirt height and degree of leaflet overhang may influence THV performance, durability, and ability to access the coronary arteries. The higher the second THV, the taller the new skirt, with high risk of sinus sequestration. For this reason, anticipating and planning for the future should start from the first intervention with a reasonably high implant below the coronary arteries, as you can see here, with a left main plan to see and follow the implantation with view of the coronary arteries. In some patients, the second implant must be lowered to avoid for tall new skirt at the price of significant leaflet overhang, as shown here on Nico and on the bench. Commissural alignment is crucial to facilitate coronary reaccess and to avoid for early THV dysfunction. And you can see that the risk of coronary obstruction after redo TAVI is strongly related to index procedure characteristics, but also to redo procedure characteristics, which plead for taking care from the index procedure to plan for the future. This is a case-based example of a patient with a bioprosthetic valve dysfunction as regurgitation 6 years after implantation, evolute R 26 millimeter. You can see here that there was a low VTC distance for both left main and right coronary artery, and the STG VTC was virtual. We had to consider two plans, Basilica, but there was some coronary overlap here, making Basilica very difficult, or low implant at a price of a high leaflet overrun, but the non-stenotic leaflets were able to do the procedure. So we had to position the second valve in the first valve here at node 4, node 5, and node 6. As you can see, the higher the implant, the higher the neoskirt height, and decreasing leaflets overhang, degree of leaflet overhang. So for this patient, the plan for redo TAVR was to go under the plane of coronary arteries at node 4. This is what we did here. We went through both coronary arteries with guiding catheters to mark the plan of the coronary arteries, but also to protect from coronary obstruction. This is for the left, this is for the right, and this is after redo TAVR deployment. And you can see that coronary arteries are both perfectly patterned with no problem. And we had this CT done at 3 months. You can see we have very, very low leaflet overhang. We just have some kind of one leaflet here with retracted fibrotic tissue and no problem for the hemodynamics in this patient. So the Redo TAVR app is now available since a couple of weeks. It's a very helpful tool to plan for step-by-step procedure, individualized strategy for the patient. My take-home message is that optimizing the index procedure is key for the future. Planning for the future before the index TAVR is selection of TAVR design, implant depth, and commissure alignment. We need individualized approach, especially in younger patients, and with definitely more data. Thank you very much.
Wonderful lecture. Thank you very much, Dr. Garot. The third speaker is Dr. Tsuyoshi Kaneko from Washington University School of Medicine, USA. The title of his lecture is TAVR Explant, the next challenging issue in the lifetime TAVR management. Dr. Kaneko, please.
Thank you so much for the invitation. I get to talk about TAVR Explant. I am a surgeon, that's my disclosure, in addition to all these. So this is the latest information from TVT Registry in the United States. There's 823 sites. This was as of April 2023. And you can see that most of them are in Florida, California, and then in the Northeast. And Dr. Grube already showed this, but the number of TAVRs has surpassed the number of surgical AVRs. The blue number on the top is all surgical aortic valve replacements, and TAVRs surpassed that back in 2018. In 2022, the number of TAVRs being performed was 98,000 cases. In 2023, we anticipate that this is over 100,000. However, in the United States, 65 is sort of the cutoff for the guidelines. Under 65, there's a Class 1 indication for SAVR. This was presented at the STS using a California state database. In 2021, 45.7% of all AVRs were TAVRs. And this was already shown, but in 2021, this is the national Vizient data, 47.5% underwent TAVR in patients under age 65. And we know that all of these biprosthetic valves will fail over time. And if you're younger, these valves tend to fast. This is from the surgical literature. So what we're going to see is tsunami of all these failed TAVR valves in the future. This was shown earlier regarding the TAV-in-TAV. The outcomes of TAV-in-TAV is fantastic. The 30-day mortality is extremely low. The figure on the right is a SAPIEN series of TAV-in-TAV recently published in Lancet, and it showed that it is actually equivalent to the native TAVR. However, there are issues with TAV-in-TAV. In the previous talk, the sinus sequestration was discussed in detail, and the percentage is not low. With the CT prediction, about 20 to 40% will not be able to get TAV-in-TAV, but just do basilica in those cases, people will think. But you can see that this is Jafar Khan's study. In TAV-in-TAV, even if you do basilica, the leaflets don't open as much, especially if you're putting an evolute inside of prior TAVR. And also, if you have non-commissural alignment, even if you split the valve, it's going to be an issue. So what do you do in those cases? You have to take it out. You have to ask the surgeons, unfortunately. It's been said multiple times, but the TAVR explant have reported to have very high mortality. The 30-day mortality has been somewhere between 10 to 15%. And the problem is that these are not really old high-risk patients. This is the TAVR explant registry with Vinny Bapat. The age of these patients were 72, and the STS at the original TAVR was 4.8%, with 28% being low risk. This was the Medicaid study that we did, also showed that the TAVR explant mean age is about 73. So these are non-old, non-high-risk patients that were seeing a lot of these high mortality risks. This was the latest data that was presented at the STS using the STS database. So in 2023, 1,600 surgical cases were performed who had previous TAVR. The blue line is the TAVR explant, which the patient needed a new TAVR valve, new aortic valve. And the mortality in these, as reported previously, was high, 14.1%. So again, confirms the high mortality in these cases. So why is the mortality so high? Part of the issue is that the TAVR explant is done by a very small number of surgeons. This is relatively an old data, but from 2011 to 2018, median case per surgeon who had performed TAVR explant was 1. And per center, it was 1. So not a lot of experience of taking out these TAVRs. So I'm going to show you 2 videos that I've taken out. The left one, obviously, this is a sapien valve that I took out. This is after 3 years. And you can sort of see the valve thrombosis that occurred and led to structural valve deterioration. To the right was endocarditis from Evolute valve. And in the Evolute valves, because of the hourglass shape, it is more stuck to the aorta. And you can see that it takes a little more effort to take these valves out. In this particular case for the Evolute, I put a purse string suture in and then put a tourniquet, just like sheathing the valve into that tourniquet, which allows you to dissect a little more easier. You can see that the sapien valve is really stuck at the level of the skirt near the aortomitral curtain. But once you get to that space, you can actually go into the plane between the native valve and the TAVR valve, and it does come out relatively easily once you are able to dissect it out nicely. And on the right side, after putting the tourniquet on, I'm using the knife to cut it away from the valve itself. So you do need to have some technicality to explant these TAVRs, and that's part of the challenge. So what have we done so far as a society? This is the AATS webinar that we held. That's one thing we did. In the Redo TAVR app that Vinny Bappa created, there's a TAVR explant session where we show a lot of these videos. And most recently, we've come up with with sort of a technical consensus statement published in the JTCVS in collaboration with the Heart Valve Collaboratory. So all of these efforts are putting in place so that people can learn how to take these valves out. So we haven't really compared the outcomes of TAV-in-TAV and TAVR explant. This was one of the papers that we did using a Medicare database. And as we expect, the 30-day mortality for repeat TAVR was 6.2%, and for TAVR explant, 12.3%. One of the key things that I do want to send a message is that the repeat TAVR in very elective setting, the mortality is very low, but when you look at it as a group, it's not as low as you think. It's not that 1%, 2% that is being reported. And this was the TAVR explant redo registry. And when we compared the outcomes of redo TAVR and TAVR explant, after 1 month, we call this a landmark analysis. After 1 month, there was no difference in the survival between TAVR explant and TAV-in-TAV. So more to come in this topic in the future. So what do I predict for future TAVR explant? I do anticipate that the outcomes will improve as we learn more about the techniques and even younger and lower risk patients coming into the pool of TAVR explant. We believe that complex explant probably should be done in high-level centers, and a lot of these complex replacements will probably decrease in the future. I didn't really talk about this, but the annual echo surveillance and early referral will be the key. A lot of the times, these patients were very sick when they come to seek for surgical intervention, and the volume will be higher than the repeat TAVR, but probably not as much as a redo TAVR. Lastly, I do want to emphasize the importance of lifetime management. This is the DASI Simulations CT scan AI software that they use. So what they're doing is this software makes you implant all these valves at different height, so with a different combination. So you can put Evolute at certain height, followed by a balloon expandable valve, and look for that coronary obstruction risk. And you can actually plan it even before you implant the first valve. So these will be critical moving forward in terms of lifetime management. And we should tackle this problem together. US and Asia is very far away, but we used to be the same continent. So I think we should work together to make sure that we solve this problem together. Thank you very much.
Wonderful lecture. Thank you very much, Dr. Kaneko. The next speaker is Dr. Michael Kang-In Lee from Queen Elizabeth Hospital, Hong Kong, China. The title of the lecture is TAVR in Moderate AS with Heart Failure. Dr. Lee, please.
Well, thank you, Dr. Kim, and thank you for the kind invitation again. This topic is on the TAVR in moderate AS, especially in the setting of heart failure. These are my disclosures. We know there are accumulating evidence that the TAVR has been very safe and saved a lot of patients' lives for patients with severe aortic stenosis, both high risk, intermediate risk, as well as low risk in the use of both balloon expandable valves as well as self-expanding valves. But these are all on severe aortic stenosis. And if we look at the grading of aortic stenosis, you can see that moderate aortic stenosis have these parameters, echo parameters, and then we also look at the calcium score, CT calcium score as well, which will help us actually to grade this sort of moderate aortic stenosis either into the more severe type or less severe type of aortic stenosis. So these are all important echo and CT parameters to follow. If we look at the American guideline, the latest guideline, you can see all these recommendations on intervention of aortic stenosis. They are all on severe AS except the last one. So what they recommend is a 2B recommendation, is that in patients with moderate aortic stenosis who are undergoing cardiac surgery for other indications, then probably AVR may be considered. So there's not really any recommendation how to tackle moderate aortic stenosis for now. And the recommendation to follow these moderate AS patients are just to repeat the echo every 1 to 2 years, which I think is a bit loose. I would actually follow up these patients more regularly, mainly because aortic stenosis is actually a rapidly progressive disease. You can see that every year, the mean pressure gradient is going to go up, the aortic valve area is going to go down, and the valve will be more and more calcified year by year. And the increasing baseline severity of AS, like moderate to severe AS, actually predicts higher rates of progression. So when it goes up to moderate severe AS, the progression would be a lot faster. Eberhard showed this slide before. If you look at longer-term follow-up data of moderate aortic stenosis, you can see that for moderate AS and severe AS, they both carry very high mortality for these sort of patients. Of course, you can argue that this might be because of the misdiagnosis of moderate AS, in which some of these patients might actually belong to severe AS. But I would say that maybe for patients with moderate AS, there have been already too much damage to the myocardium, and the intervention has been done too lately, so that the mortality would be very much similar to a severe aortic stenosis. There have been a number of predictors of mortality of adverse events in moderate AS. You can see all these parameters, AF, low EF, diastolic dysfunction, rapid progression, elevated biomarkers, and also high calcium score. But I would say patients with impaired EF in heart failure will actually carries a much worse outcome. In this study for over 9,000 HFrEF patients with impaired ejection fraction heart failure, when they look at the different severity of aortic stenosis, you can see that for patients in heart failure with moderate or severe aortic stenosis, they actually have more or less the same worst outcome. in terms of the in-hospital mortality, hospitalization or the all-cause mortality. And if we look at the different level of left ventricular impairment, you can see that for patients with even worse ejection fraction, less than 35, even with moderate AS, they carry a lot worse clinical outcomes. This is a meta-analysis of moderate aortic stenosis on long-term follow-up. You can see that when patients have moderate aortic stenosis, their mortality is not low at all, 9% mortality and about 5% cardiac mortality. So still, I would say this group of patients actually have more or less similar mortality or complication rate as severe aortic stenosis. And they can also identify certain risk factors, predictors of mortality in moderate AS patients, and these include diabetes, coexisting coronary artery disease, LV dysfunction, and the presence of heart failure symptoms. So whenever patients have all these other comorbidities or impaired EF, they will do a lot worse. So this is a summary. You can see that for patients with LV ejection fraction less than 50%, they carry a mortality fourfold increase as compared to patients with normal LV ejection fraction. And this is actually not a single entity. It's a spectrum from mild AS to moderate AS, all the way to severe AS. And the prognosis of these patients will be worse and worse as the AS gets more and more severe. And if you look at the more detailed staging classification proposed by Philippe Gernax, you can see that when we see more and more heart damage, like LV damage, and then valvular damage, and then involvement of the RV, you can see it for severe AS with symptoms. Patients would do worse when they have a higher level of cardiac damage. Even for patients with moderate AS, you can see that when they have more cardiac damage, their prognosis, again, is a lot worse than the early phase of the disease. Of course, there are certain arguments whether we should perform intervention for moderate AS early or we should delay the procedure. Mainly, if we want, we should do it early, mainly because the disease actually can progress very rapidly. There is a high mortality for patients with moderate aortic stenosis, especially when they have heart failure symptoms. And intervention is relatively safe now with TAVR. And there are certain risk factors that may help to modify these patients, and then they can benefit more from intervention. And then for those who do not want to have early intervention, mainly they would say, we have sort of misclassified this moderate AS. They should belong to severe AS. That's why we should intervene earlier. But again, there are still not much evidence that we can quote to support our moderate AS to go for early intervention. It all goes back to the heart team. So for patients with moderate AS, when you look at their symptoms, we look at their LV myocardial damage, and then finally decide what we want to do for this group of moderate AS patients. For now, we can only enroll them in clinical trials. These are the three main clinical trials for moderate aortic stenosis. TAVR Unload will be presented later this year. It's mainly moderate AS patients with impaired EF less than 50%, going for either TAVR or medical management alone as compare. They will be presented later this year. And PROGRESS is, again, randomization of TAVR versus clinical surveillance, medical treatment, and then a long-term follow-up after implantation of the SAPIEN valve, elderly patients, moderate AS, either with symptoms or with evidence of cardiac damage. And lastly, Explant TAVR 2 is another moderate AS study with the use of Evolute Pro Plus or the FX system. Look at TAVR versus medical treatment, and the inclusion criteria is, again, very similar. Moderate AS with symptoms, with impaired EF, or when the patient have heart failure symptoms or elevated biomarkers. So in summary, I would say moderate AS is not benign at all, especially when they have heart failure symptoms. And so there are some predictors that are associated with worse outcomes with moderate AS like diabetes, coronary artery disease, or impaired LV ejection fraction. And moderate AS with heart failure might be as bad as severe AS, and this group of patients might warrant earlier aortic valve intervention, but we still have to wait for randomized clinical trials to tell us which subgroup of patients with moderate AS actually would benefit from aortic valve intervention. Thank you very much for your attention.
Thank you very much, Dr. Lee, for your wonderful lecture. Now we are going to move on the last lecture, who is Yohei Ohno from Tokai University Hospital, Japan. The title is Smart TAVR Valve Selection in Asian Patients with Different Anatomy. What we should more consider. Dr. Ohno, please.
Thank you, Professor Kim, Eberhard. Thank you for your kind invitation. I would like to talk about TAVR valve selection, in specifically in Asian populations. We have quite unique anatomy. This is my disclosure. So Japanese patients have smaller body size, as you know. From early our experience, mean age was 84. Majority was female. The BSA is 1.46, so it's quite maybe hard to imagine from the physicians who practice in large body size, right? Body weight is only 50 kilo. We can even have like 30 kilos, very frail patients. So this is a very nice study from Hyo-Soo that shows the difference from Japanese and European anatomies. So I highlighted the Japanese anatomy, the small valve size in red here, showing that mean perimeter was 70.3 and area was 375. So if you have looked deeply into the SMART trial, I think these are the numbers that may be familiar with you. It's almost same as the mean perimeter and area in that trial. So that's quite relevant in our patient population. So 70 of the TAVI patients in Japan have 18 to 23 millimeter diameter, as shown here. Most of the patient has annular area less than 400, 430. So this study was done with my great friend So-Han-Yoon using the data from Asian populations, Japanese patients, Korean and Taiwanese patients, comparing with the Caucasian, and show that we often face patients with very small aortic root anatomy, left main coronary artery height less than 12, as well as LCC diameter less than 30. So 30 to 40% of the patients falls in this anatomy. So there are some potential risks of performing TAVI in these small anatomies. Though these are highlights which we can consider. Process patient mismatch and coronary occlusion, potentially sinus sequestration, even with the first initial valve implantation, as well as a vascular complication. So what do we know about the PPM after TAVI? I would like to focus mainly on PPM for the sake of time. So this is the data from the TVT registry showed that incidence of PPM is not low, right? 1 in 4 patients develop moderate PPM after TAVR, and 12.1% develop severe PPM, which translates to clinical outcome. Patients with severe PPM has worse mortality. So this is a registry-based study from the small TAVI registry showed that different valves behaves obviously differently. So intra-annular valve carries high risk of PPM with odds ratio of 2.4, whereas if you perform post-dilatation appropriately, maybe it attenuates the risk of PPM. And the right-hand side shows the exact same data result with the TVT registry showing that only the severe PPM patients have poor mortality, whereas the moderate PPM did not impact the outcome. For the Japanese population, this is from our Ocean TAVI registry, obviously we have small body size, so by equation of calculating PPM, the incidence of PPM is only like 10% in our cohort. However, both in small and large BSA patients, small annulus was significantly associated with higher PPM, so we should obviously take into account. And maybe the million-dollar question is, did this PPM really relates to the valve durability, right? Structural valve deterioration. There are all still limited data, but some data are coming. This is from the cohort from TAVR that shows that PPM related to structural valve deterioration. And this recent meta-analysis also showed that it carries a risk for SVD. So going to the SMART trial, as you know, it was a randomized controlled trial using the small aortic annulus defined by CT scan less than 430 of annulus area. Actually, 17% of the patients was excluded, mainly because of the LVOT calcification, so on. To be fair, both with the balloon expandable and self-expandable platform, 1-to-1 randomization. And they had two actually co-primary endpoint. One, clinical endpoint, which was powered for non-inferiority. The other one was valve hemodynamics, which was powered for superiority in this specific trial. So mean age was 80 years old. Majority was female, almost 90%. And as I mentioned previously, the mean area and mean perimeter of this cohort was 380, and the perimeter was 70. So more or less that we often face in Japanese, maybe Asian patient population. As for the self-expandable platform, 26 millimeter Evolute valve was mainly used, whereas for balloon expandable valve, SAPIEN 3, SAPIEN 3 Ultra, 90% was 23 millimeter valve. So as you know, for the co-primary endpoint 1, clinical endpoint, there was no significant difference at 12 years. This study is going to be followed for up to 5 years at least. So the 5-year outcomes will be a very exciting data. As for the valve performance, mainly due to structural valve, hemodynamic structural valve deterioration, has superiority was met for self-expandable suprannular platform. So as shown in the summary, non-clinical outcome, non-inferior clinical outcome at 1 year, superior valve performance at 1 year, and it was actually related to the QOL patients who had received suprannular platform with self-expandable platform had significantly improved the KCCQ score. So it has a relation to the clinical, at least from clinical symptom at this moment. So how does this clinical trial impact our valve selection? Obviously, we need to carefully take into account this valve performance result from this trial. But you know, it's not that simple. Since we have small valve anatomy for Asian population, it means that the root is small. So we also need to consider the coronary access, so on, and the potential redo TAVR, right? Repeatability of the procedure. So it's quite complicated. So we all need to take into consideration these aspects. Ease of use, shorter procedure time, I guess SAPIEN valves favors. Valve performance, as we looked in the SMART trial, I think the Evolute has a huge advantage in this setting. Coronary access favors shorter valve frame, but if we can achieve the commissure alignment, I think the valve coronary access would not be a problem even for the high transcatheter heart valves. In terms of repeatability, I mean, the potential redo TAVR, short valve frames favors, as you know. And for the access, 14 French sheath is, I guess, the lowest profile system at this moment. So we need to take into account all these things, and obviously the patient's age, life expectancy, and anatomy matters. Thank you so much for your attention.
Thank you very much. We have panelists, Dr. Gurvitch, Kaneko, Palmerini, Poon, Shirai, Testa. Dr. Grube will chair the discussion time.
Yeah, so thank you very much. It was great presentations. First of all, are there any comments, remarks from the audience? Any questions? That is not the case. Then we have to kind of roll up, and we had impressive data, particularly when we look at the explant situation. You called it the tsunami of valve and valve. I kind of like that expression. We have to, I think, to really look into this a little bit more. Do you believe that that training the surgeons will lower the mortality? And there's clear difference between the shorter frame valves and the larger valves. Do you think that the training will help?
I believe so, and I hope so. On that STS paper, I didn't have time to go into the details, but on the most recent years of TAVR explant, the mortality was about 9%. So compared to the 20% and the 15% that's reported, it is coming down. So that is our hope, but we've got a long way to go. And part of the problem is that they come in very, very sick. They often come with LVEF of 30% with RV dysfunction and severe MR and severe TR. So we want to make sure that they come a little earlier. So I think that's part of the things that we have to do a little better.
I have a connected question. Is it more, so the reason of this high mortality is more the patient or the technical difficulty of the operation? And which is the technical difficulty of the operation? Is there an increased risk of damaging the ventricle, damaging the aorta, or why these patients die because of surgery?
Right. I think it's both, but the technical aspect, I didn't have time to go in, but if you injure that aorta, especially near the coronary artery, you have to do what we call a root replacement, which becomes probably twice as big as an operation. And you have to reconstruct the coronaries. There's a chance that the coronary may kink. I think all of that becomes an issue from the technical standpoint.
But is it true that the need to make a Bental or to, fix the aorta is very small?
That is correct. There has been some data showing that if you do a root replacement from that TAVR explant registry subgroup analysis, that the mortality is higher with root replacement. So the answer is yes.
Just to expand on that, what do you think would be the current explant mortality if you took patients just with degenerated valves who are clean, like without endocarditis, without concomitant severe MR, TR, pulmonary hypertension from their other illness? Because a lot of these valves are coming out of 3 years. Obviously, something's wrong rather than a normal valve just deteriorating. And whilst we should approach TAVI and lifetime management with a concept of never wanting to do a TAVI explant. Yes. But what do you think is the mortality of just a clean patient, restenosis, mean greater than 40, otherwise well?
So that is, the answer to that question is please stay tuned. So Vinny Bapat and others, including myself, is going to work on that series of doing elective TAVR explant. So that data's coming up. So
that's really the...
I do agree, yes.
But so if I have a comment about it, do you really think that if you have such kind of patient, surgery is an option? I mean, if we say, this otherwise fit patient with a previous TAVR, is it really a candidate for surgery? I'm not sure. Especially because if TAVR was a good idea up front, why now surgery is a good idea, considering what you just said as a premises? If this patient is still fit, fit for surgery, but still fit for TAVR, how can we balance the risk of surgery when we have an option that is way more invasive, if you see what I mean? This is really, it's a big point, I guess, because if TAVR was a good idea and it's still feasible, we should go that direction, I guess.
I have a pro comment and a pro and con comment on that.
Sure.
So Eberhard showed that slide of redo TAVR increasing, right? So I think the first option will definitely be redo TAVR, TAV-in-TAV, if it's feasible, right? The con to it is the risk of sinus sequestration.
Of course.
But also, one thing that we don't talk about enough is the risk of PPM. When you look at the size of the valve, when you calculate the area after a TAVR, those areas are often in 200s. They're very small.
Yeah.
So, there will be some degree of gradient that Thurani paper, Raj Makar paper that I mentioned in Lancet, the only difference between native TAVR and redo TAVR was a gradient afterwards.
Yeah.
So there will be significant gradient afterwards. And Dr. Ohno's talk, grading is going to be
Yeah, if I can actually expand on this, Eberhard, sorry. And it's not just a criticism for surgeons, but a call for action. A thing we are not talking about a lot is the annulus enlargement technique. And I can say that, at least in Italy or in Europe, it's not happening. So we all talk about the fact that all the problems are basically related to small anatomies. But still, surgeons taking their time and training to enlarge the annulus in order to place a bigger valve with less complications over time, we all know that. They are not there. So we should probably, let's say, reevaluate our technique. Surgeons should do the same in order to increase the number of large valves. Because we all know that all the problems concerning TAVR-in-TAVR are basically related to small anatomies. A big anatomy is not a concern, to be honest. So this is a thing we should discuss further.
Yeah, can we just briefly, Hyo-Soo, you are a big fan of several valves. When you look at the SMART trial, do you think that balloon expandable versus self-expanding is kind of a group effect, or do you think it has something to do with intra-supraannular? Would you, Dr. Ohno just included the Portico valve into the selection because I guess it's approved in Japan. Do you think that the data, to some it came surprising, to some it was not surprising, would be the same with Actuate, for example, or with Portico?
In Korea, Portico is not available. Thus, I understand the data of SMART RCT, just comparing Evolut and Sapien Ultra. I totally believe that data before the exposure of that data, because I really believe the effective orifice area immediately after TAVI between the Evolut and Sapien. Thus, in our institute, I try to avoid implantation of Sapien 23. So in our cohort, all the Sapien treated patients, the valve size 20 and more than 26. When we consider such kind of, as mentioned, Dr. Kaneko, when we consider TAVI and TAVI, the first TAVI effective orifice area is very important. Thus, at least in East Asia, I think SMART RCT data is very important for us to choose the first TAVI valve. That's the reason, that's the start point of my question to Dr. Ohno. I believe the Sapien market share is about 60% in Japan, dominant over Evolut. Do you expect some kind of change in market share for you seeing SMART RCT data?
Well, that's $1 million question, I guess. Well, I think, physicians does not change their preference immediately, but over time, I think it will gradually change. But I think most of the so-called Sapien users are waiting for long-term clinical data, because we know from the JAMA cardiology paper that hemodynamics deterioration translates to clinical outcome. The incidence of hospitalization for heart failure and mortality had a hazard ratio of like 2 to 3 in that patients who developed SVD. So I believe in the long run that Kaplan-Meier curve of the clinical outcome could be significant over time. But because, as I mentioned, we have very small sinus of Valsalva, low coronary height, those kind of issues is quite relevant as well. So, well, let's see. Gradual change, I think.
Yeah, it's a diplomatic answer, like we would expect from him. And it is totally understandable. My answer to that would be a little bit less diplomatic. The reason being that physicians are very conservative, and once they've made up their mind, at least in my view, once they've made up their mind, they will stick to it, unless there's some real heavy data that would restrict them from using it. I don't think the market will will change. I think it is interesting what we see, and it is proven that it has some benefit. Whether or not this translates into market share remains to be seen. I don't personally believe it. I think life will continue as it is, and we will summarize the SMART trial into one of the interesting randomized trials. And I think certainly it's an interesting one, but I don't think that physicians would change that. The same thing, the durability data, the discussion we had, a fierce emotional discussion that we all remember when the 5-year and the 4-year durability data came out. You remember when durability was a topic. Now it's not so much a topic. It's, it is what it is. And now it changed to coronary access, and these things are changing. I think we're running out, but before we close, I would like to really ask the panel about aortic regurgitation, because aortic regurgitation is something that's not only underdiagnosed, but it is terribly undertreated despite guidelines. Even we have very successful means in surgery with surgical treatment. Patients are not referred to surgeons, and if we look at the percentage. So would anybody agree on the panel that for aortic regurgitation, imaging, grading, and intervention has to be redefined? We're moving into the same kind of direction that we move with aortic stenosis, intervene earlier to avoid damage. Any comments on that?
Yes, and I also think that probably it is time to do a randomized trial against surgery intervening earlier, because now we have a very effective method to treat aortic regurgitation, and I think it's time to face against surgery.
Yeah. Anyone?
There's a trial that's coming up in valve, including the low risk and the intermediate risk surgery versus the valve. So that's upcoming. And I see Dave Cohen on the crowd, but I think the MRI, the CMRI will be critical moving forward. I think you mentioned that, Eberhard.
Yeah. One thing has to be considered, Eberhard, if I can. The valve has a limited size range, so there are multiple patients where there's no transcatheter option. And still surgery is the only thing that you can do. But we all agree, I guess, that the earlier, the better. But for randomized controlled trial perspective, we are selecting patients anyhow. Because, as you well know, I mean, the enlargement of the aortic root, and the enlargement of the LV, the enlargement of the aorta, the disease of the aorta is something different. I mean, it's a different disease compared to stenosis. In other words, to use transcatheter option, we need to really select patients. Surgery, when suitable, is suitable for everyone. So that's a big difference still.
So at our institution in Australia, we any moderate symptomatic aortic regurgitation, they all have cardiac MRI to quantify the regurgitant volume, number one. Number two, I think the dedicated transcatheter heart valves for AR is already shown. When you treat the AR, LV is not what it is. So that's a warning that we're missing the boat.
The other big thing about AR, of course, is that if you miss AS and the ventricle goes off a bit, it recovers. With AR, it's unforgiving. If you miss the timing and your ventricle dilates too much or goes off, you can fix it and then it doesn't get better. So it's of paramount importance not to wait too long.
Well, that was the problem, missing the point, because the grading was echo, and we know now that echo is simply not enough, or good enough, I should say. So we have to look at other imaging modalities in order to find the right time. So I think time is up. I wanted to thank my good friend here to the left, who is always kind enough to guide this session. And thank you for your attendance in difficult times, as I said, in Korea. Thanks for my European and OUS partners and friends. I wish you a very successful TCTAP, and thank you again, and let's close the session.